Hello, and welcome to today's webinar, Multimorbidity and its Health-Related Consequences. This webinar series is coordinated by the Aging Initiative, which is an NIA-funded initiative that bridges the expertise and leadership of two powerhouses for research on multiple chronic conditions, the Healthcare Systems Research Network and the Claude D. Older Americans Independent Centers, or Pepper Centers. The Aging Initiative is led by Dr. Jerry Gurwitz at the University of Massachusetts and Myers Primary Care Institute, along with co-PIs Elise Adams and Jay Magaziner. My name is Heather Whitson. I'm an Associate Professor of Medicine and Ophthalmology, and I'm the Director of the Duke University Aging Center. I'm part of the Aging Initiative Dissemination Workgroup, which is co-led by Leah Hanson at HealthPartners. Before we get started, I need to cover a few technical details. Due to the number of registrants for today's webinar, we have placed the phone lines on mute to reduce audio feedback. So unless you are logged in as a host or a panelist, your line is muted. However, we welcome and encourage audience participation using the Q&A and chat features of the webinar software. If you're in your Cisco webinar portal, look at the row of circles across the bottom center of the screen. Clicking on the chat bubble icon until it is highlighted blue will allow you to chat. If you have questions for our speakers, please click on the Q&A tab on the right side of the screen and type in the Q&A box. Leah and I will keep an eye out for those questions under the Q&A icon. As time permits, we will read questions for our speaker after the presentation. If you have technical or logistical questions, we ask that you submit those using the chat box that is above the Q&A box. Please make sure that you're identified by either your name or participant ID so that our webinar hosts will be able to help troubleshoot any problem that you're having with audio or other issues. With the chat function, you can choose whether you would like your comment to be visible to all participants, or you can choose to send the question only to the hosts. We extend a huge thanks to Catherine Anzoni and Chris DeLude at the Myers Primary Care Institute, who do amazing work behind the scenes to make these webinars possible. Catherine will be monitoring the chat function today to help with any of the technical troubleshooting. And now I'd like to introduce today's speakers. We'll hear from Dr. Ana Quiñones, an Associate Professor in the Department of Family Medicine at Oregon Health and Science University. She's a gerontologist trained in Health Services Organization and Policy from the University of Michigan School of Public Health. Her research interests address racial and ethnic differences in age-related changes coexisting with chronic disease and healthcare delivery changes designed to improve the management of chronic diseases for vulnerable older adults. We'll also hear from Dr. Melissa Wei. Melissa is a general internist and clinician investigator in the Division of General Medicine at the University of Michigan. Her research addresses multiple chronic conditions, including its measurement, management, prognosis, and prevention in aging and older adults. She completed a series of studies to develop and validate the Multimorbidity Weighted Index, a person-centered measure of multimorbidity that weights chronic conditions by physical functioning. She is funded by a Career Development Award from the NIA to develop and validate the Multimorbidity Weighted Index and administrative data and quantify its impact on patients and healthcare systems. Melissa is also one of our MCC scholars in the Aging Initiative. Without further ado, I'm going to hand it over to Ana and Melissa.
Great. Thank you so much, Heather. Let's see. All right. Are you all able to see my screen?
Yes, we are, yes.
Perfect. Wonderful. Well, thank you so much for inviting me to contribute to this talk. Melissa and I today are going to be talking about multimorbidity and its health-related consequences. I will talk about our work here at OHSU and raise some issues related to multimorbidity measurement in special populations, and specifically from a longitudinal framework, really advancing our work in thinking about how to measure and how to construct multimorbidity from a cross-sectional viewpoint to then, again, thinking about advancing that in measuring it over time and changes over time. And there'll be a specific aspect to my talk where I will raise and consider some issues pertaining to the tracking of these changes in multimorbidity, specifically among racially and ethnically diverse populations. So first of all, I wanted to note that I have no financial conflicts of interest to disclose, but I did want to mention funding sources from the National Institutes of Health, National Institute on Aging, and the obligatory statement that the views expressed of this talk are my own and my team's own and don't necessarily represent the official views of the NIH. So any mistakes are ours, not theirs. So by virtue of the fact that all of you have signed up for this webinar and this talk, I think it's safe in assuming that everybody here understands the importance of multimorbidity and really the last nearly 20 years of research that have really led us down this path of considering multimorbidity as its own clinical entity and recognizing the importance and the compounding effects of having sometimes synergistic multiple chronic conditions whose effects on a patient's life is above and beyond the risks attributable to any of the single component individual conditions. And again, these last nearly 20 years of research have really led us down this path of this pretty robust evidence base that multimorbidity is not only prevalent, especially as you age, but also very disabling and costly to healthcare systems and to patients. The question here is somewhat contingent on how we measure multimorbidity and thinking about and advancing the field on how we can measure multimorbidity well. So the field is in some kind of flux about how to measure and operationalize multimorbidity. There are, and I'm sure that you're aware, hundreds and hundreds of articles out there who are not exactly consistent on the way that we measure multimorbidity. But I think the latest thinking around this is to really have an organizational question around for what purpose, really. So this best recommended practice is to be as transparent as possible and really report how the measure is constructed, as well as the assumptions and the rationale used. And of course, I think tied into this issue are measurement issues around data sources themselves. So it's probably worth mentioning the variety of data sources that we use in measuring and tracking and reporting on multimorbidity, whether it be electronic health records, EHR data, survey data, longitudinal survey data, claims data. There are a variety of issues, limitations, and advantages of using any of these sources of data with regard to their accuracy, their completeness, and their quality. So these certainly build into how we measure multimorbidity and what some of the limitations might be in the way that we measure multimorbidity. What I'll focus today on talking about really is also contingent on the tension that we have in the field of balancing tailoring measurement for the purpose or the objective, so for what that purpose question, but also balancing that against comparability or standardization or being able to compare your study's results to other studies in the field and in the literature in general. So first thing that we think about is what do we include in the numerator? So there are multiple multimorbidity frameworks out there that provide some general guidance criteria for inclusion, and generally these center around conditions that are chronic. So once you have them, incurable. They are important for aging populations, and notably, these often include both mental and physical chronic conditions. There's a seminal paper by Goodman and colleagues, sponsored by the Office of Health, the Secretary of Health from the Department of Health and Human Services, Goodman 2013, I believe, where OASH really used a deliberative process involving a multiple chronic conditions working group, subject matter experts in clinical medicine and epidemiology and public health. And the goal here was to develop a list that would include conditions that meet these definition of these criteria for chronicity, prevalence, and that are also potentially amenable to some kind of intervention, whether it's public health or clinical intervention. The result of this, if you take a look at that paper in this table 3, is a list of 20 recommended chronic conditions, ranging from cardiovascular, metabolic, but also including dementia, depression, diabetes, substance use disorder, a really nice comprehensive list of questions that provide a good guiding framework for that numerator and how we think about multimorbidity measurement. And of course, again, not all of these chronic conditions are always available or discoverable or complete across sources of data, which makes things a little bit difficult for those of us that are interested in studying multimorbidity. Similarly, and this is where I spend a lot of my time thinking about the denominator, so how we can think through those important issues of multimorbidity measurement and how they apply to which populations are included in studies. So there are some really important considerations with regard to vulnerable populations specifically, who may be or may not be included or sampled, but where we have to be really attentive to issues such as age ranges that are included. So for example, are we thinking about middle age, pre-retirement age and older? Are we thinking about Medicare beneficiaries? Or should we be pushing earlier in the adult life course and thinking about middle age and earlier middle age? So in our work, we think it's really, really important to be as accurately as possible, or to as accurately as possible, represent multimorbidity burden for minority ethnic populations and other historically excluded populations from research, because really the ultimate goal here is impacting and informing not only clinical practice, but also policy, resource allocation, and geographic distribution of programs and services that are going to be responsive to the needs of populations. In thinking about that, we were attuned to these issues of measurement. We were attuned to these issues of observation period. For example, one of our recent studies, we were really looking to track multimorbidity accumulation. So in this case, we operationalized this as the increase in the count of chronic diseases over time, crude but effective. And we were interested in comparing this progression or accumulation of chronic diseases between white, Black, and Latino middle-aged adults over a 16-year period. So what we found was that Black Americans already started off with a higher initial level of chronic disease burden compared to their white and Latino peers. And they crossed that multimorbidity threshold on average about 4 years earlier than whites do. So our findings also showed that while Latinos were comparable in their initial levels of disease to white Americans, they were accumulating chronic disease at a faster rate over time. So this is all to make the point that for some specific populations and for some specific research questions, we really might need to be cognizant of and thinking about the trends or the mechanisms that may be operating for subgroups. So for example, if we're interested in targeting or preventing multimorbidity onset or delaying multimorbidity onset, these results might suggest that we should be intervening on minority ethnic populations earlier in the life course. There also might be some important multimorbidity patterns and trends, such as prevalence or age of onset or the course of multimorbidity progression, that might look really, really different among other vulnerable populations, such as patients that are being seen in the safety net. So these are patients that are potentially uninsured or underinsured or of low income. So we're just now beginning to work with the Advanced Data Network, which is a repository of EHR, electronic health record data, on patients seeking care in community health clinics and federally qualified health clinics. So these are data across approximately 27 states and between the order of 1,200 to 1,300 clinic sites. So this is very, very preliminary, but this gives you a sense of where we're going with our examination of these data. So these plots show us just, what kind of chronic conditions are more likely to be seen in the network of safety net or FQHC clinics over the course of 10 years, so from a period of 2009 to 2019. So we looked at the frequency of occurrence of the 20 chronic conditions recommended by the Health and Human Services framework that I presented earlier. And what really struck us, at least in these very preliminary scans, is among the most frequent diagnoses, we see some corollaries to what we see in national longitudinal representative surveys. So hypertension is top of the list there. But it also interests us to see that substance use disorder and depression are also frequently occurring in this clinical population. Again, trying to think about some specific needs of particular groups or pockets of population that we need to be attentive to. And of course, this doesn't tell us anything about which chronic conditions are most frequent in combination. So we're working towards describing multimorbidity patterns and understanding how those multimorbidity patterns progress and change over time for the safety net population, but this at least gets us thinking about diverse populations that may have some specific chronic care needs. So these are some of the issues that we're grappling with now in thinking about our own projects, and we thought it would be really useful to lay out and really start a conversation around discussion of issues and knowledge gaps, from really shifting our thinking of measuring multimorbidity in a cross-sectional framework to a longitudinal, to this time-varying or this changing measure of multiple chronic disease burden and patterns and combinations as well. So we raised these issues in a recently published commentary piece in the Journals of Gerontology and Medical Sciences. And we wanted to, as I said, not only provide some recognition or at least initiate that conversation of what might be some of the big pitfalls or the big knowledge gaps and advance that field. And we identified these three main areas. So these are by no means comprehensive, but they are what we identified in terms of our team and our group and working through our projects and our papers, three big issues that we had to grapple with and that we wanted to get some clarity on. The first being longitudinal inconsistency of chronic disease reports over time, and I'll define that a little bit more clearly in the following slides. Trying to think about and measuring or assessing severity in the progression of multimorbidity over time. And then again, thinking about the representativeness of this data. So how are we able to capture an accurate picture of population level burden of multimorbidity on multiple segments of the population? So as promised, longitudinal inconsistency, here we're really thinking about how can we try to reduce the noise by addressing what we're terming clinically inconsistent patterns of chronic disease over time. And here I need to point to my colleague and co-author, Christine Segoli, who has a paper describing this issue and analyzing this issue in the Journals of Gerontology, Social Sciences, and in a publication that we put out there a couple of years ago. So by clinically consistent patterns, so we thought about in a longitudinal framework, in a repeated observation survey, where we see respondents coming into the survey and we re-interview them at particular intervals in time. What we were thinking about in terms of, well, what makes sense from the perspective of having a chronic condition that is chronic by definition and incurable. You can have patterns that are consistent, such that respondents come in, report, has a doctor told you that, for example, you have diabetes, you report no in 2000 and 2001, but come the time that we re-interview you in 2002, yes, a doctor has told me that I have diabetes, and subsequent to that time point, you affirmatively respond to that question. Other clinically consistent patterns, always responding in the negative or always responding in the affirmative. But we noticed that in some data, we did see a really non-ignorable proportion of respondents who were flip-flopping between an affirmative response, yes, I have diabetes, to a subsequent re-interview of no, a doctor has never told me that I have diabetes. And these were really the ones that we singled out as problematic and clinically inconsistent. So when we talk about this in the paper, in the commentary piece, we're thinking, you know, this really has some important implications when moving from a cross-sectional context of measuring multimorbidity to a longitudinal one. So you may not be aware of these inconsistent patterns if you're just looking at one point in time. In fact, you wouldn't be aware. You would only discover this once you start to stack up or line up multiple responses within individuals or multiple records within individuals over time. And you can see these patterns of inconsistency. So you're at least able to assess them and figure out ways to clarify with possible algorithm development or validation or additional data sources. But the implications in terms of the consequences to prevalence estimates are clear, right? So we don't know how that might look wave to wave, period to period, if you're just looking at multimorbidity construction in a cross-sectional context, versus you may be able to improve the precision of those prevalence estimates when you expand and think about this in a longitudinal framework. So we know that for some administrative data, there's some really great, valid and reliable methods to measure chronic disease diagnoses that partially address this issue. So here I'm thinking, for example, of the Centers for Medicare and Medicaid, the CMS chronic condition warehouse algorithms. But there really aren't any valid and reliable methods to adjust for these inconsistent self-reporting of chronic disease status over time. So one strategy that we were thinking about is to use all available data resources that you have at your disposal to try to triangulate information on chronic disease status. So this might include information in surveys and in the clinical record of prescription medication data use, of laboratory data use, of procedures, diagnostic test values. All of these we can use to try to corroborate chronic disease status, to really provide some evidence of having that chronic disease. But ultimately, we recognize that we need to develop valid and reliable algorithms and procedures, recommendations to try to maximize information from the patient, maybe from the self-report, but also maybe thinking about linking to clinical records and to administrative data sources. That might help improve and clarify those patterns. So in terms of severity as the second identified measurement gap, so here we're really thinking about trying to improve the ability of measuring and reflecting progression and complications over time. So how do we measure this? So we know that severity scales exist for some chronic conditions, some of those chronic diseases, those 20 that I presented earlier on today, but they don't really tell us anything about the interaction between multiple chronic diseases and how that might be affecting the total organism or the total individual. So to illustrate the measurement issue here, we have a really, really simple example with these two Meeple patients who have the same demographic profile. They have the same multimorbidity profile. They both have arthritis and hypertension, but this combination may be really markedly different between these two patients. So how do we really quantify how this combination may have really distinct differences on the impact on patients' lives for patients A and B? So again, if we think about this from a cross-sectional context, we may be able to assess severity linked to function or to some other patient-centered health outcome at one point in time only. And from a longitudinal context, when we move it from cross-sectional to longitudinal, here we can really start to see changes in multimorbidity that could be linked to changes in function or other important identified patient-centered outcomes that we might be interested in, so that we move from no real understanding or clarity on temporality, what might be influencing what, to really improving inference around the timing of new chronic conditions added on to combinations and what the health outcomes might be of those particular combinations. So again, here, to make some headway, we were really recommending and thinking about, it'd be really, really nice if we were able to assess severity in the context of having a particular assortment or combination of multimorbidity that could really account for subsequent impairments or losses. So a crude way is just to look at the simple count to measure this, but maybe a better way is to develop and validate population-sensitive measures of severity that really assess this kind of global outcomes that matter to patients and matter clinically, such as function, self-rated health, treatment burden on patients' lives, or other patient-centered outcomes or important clinical outcomes that really represent more the consequences of multimorbidity. So for example, Melissa Wei is going to be talking in a few minutes about a validated multimorbidity index weighted to prospective physical functioning. So this is really, I think, what gets us a little bit closer to thinking about the severity of particular multimorbidity combinations and could provide us some really valuable insights into changes in multimorbidity over time and then across populations. And then finally, I think a really, really important issue, but maybe a little bit more of an amorphous one, we really need data to be able to capture an accurate picture of the population level impacts of multimorbidity on all segments of the population. So really this encompasses issues such as access to care, continuity of care for underserved populations, and underrepresented populations in research. So having that more complete picture also leads us to examine inclusiveness and representation across the denominator and operationalizing multimorbidity. So from a cross-sectional context, if we're just thinking about this in a nuts and bolts data way, we really have no way to identify who is it. So of those folks that were sampled and that should be included, or those folks that are being seen in particular clinics and EHRs, in a cross-sectional slice of that, we really aren't able to identify who is excluded at any particular time point. And while messy, at least in a longitudinal context, and again, depending on length of follow-up, we can at least examine before and after to ascertain missingness, correlates with missingness, multimorbidity patterns prior to loss or censoring, and these can really provide us some really important insights. So again, cross-sectionally, we really have no way of thinking about consequences of prevalence estimates where we may have that be improved in a longitudinal context. So here's where the amorphousness comes in and trying to think about ways that we can make headway into the issue. So there are some very important policy changes that have happened here in order to strive for close representativeness by race, ethnicity, and beyond. There are other historically excluded populations in research. In conducting surveys, we should really continue to advance efforts to maximize response rates and to account for non-random attrition. And these policies, such as the ones by NIH-sponsored human subjects research, now really encourage or try to hold us accountable to justify and include individuals across a wider ages of the lifespan. So this is really important with regard to minority ethnic populations and multimorbidity, because we see that they're already coming in these typical observation time windows when we're thinking about gerontological and geriatric studies, already coming in with a pretty high burden of chronic conditions. So trying to observe earlier in the lifespan really gets us to thinking about critical periods of multimorbidity progression and chronic disease accumulation. So in summary, progress on studying multimorbidity development and progression in clinically meaningful and methodologically reliable ways remains challenging, but I think it's a really exciting time for the field. There's some important opportunities. Some of these are a little bit nuts and bolts, right? So we should strive for and try to have better consistency in reporting of how we measure multimorbidity, especially how we measure it over time. We can standardize the frequency and the timing of assessments so that we are able to calculate rates. We can assess problems with data quality, inaccuracies, reporting biases. These are all with the goal of improving data quality. But it's also really important to assess the impact of multimorbidity on patients' lives, really linking it to health-related quality of life costs or penalties of multimorbidity. And again, to really enhance the representativeness of population studies so we can get an accurate picture of multimorbidity burden across multiple segments of the population. And here, of course, the ultimate goal is to provide better assessments and predictions for the impact of multimorbidity across the lifespan, and it may uncover ways to improve care for these clinically complex patients. Wanted to acknowledge my collaborators and my co-authors and my team and my students. There have been many, many people that have helped with this effort, so they're very appreciated. Also acknowledge funding sources. And I am not sure if we're taking questions now, if we're going to wait till Melissa presents and engage in a more robust discussion then.
Thank you, Anna. That was a fantastic talk. We usually do wait until both of the talks are done. So I'll ask Melissa to go ahead and start, but this is a good time to just remind people that if they would like to submit questions, to please use the Q&A function. And after Melissa's talk, Leah and I will be happy to read out those questions and we can discuss. Thank you.
Hello, everyone. Can you see my screen okay?
I can't see your screen yet, but we can hear you.
Melissa, if you're able to go to the top menu on your WebEx and go down to share my screen. Is that option showing? Perfect.
Yeah. Okay.
There we go.
Okay. Great. Thank you so much.
Thank you.
Okay. Thank you, Anna, for a wonderful and thought-provoking presentation. And thank you, everyone, for joining us today. So for the second portion of today's talk, I will be highlighting a person-centered measure for multimorbidity, including its development, validation, and prognosis. I have no disclosures, and I'm grateful for the funders of my research. So in this presentation, I will cover three primary objectives. First, I will introduce the construct of multimorbidity briefly, and I will describe a patient scenario to highlight a case. Second, I will describe some current metrics for measuring multimorbidity and highlight one patient-centered measure. And finally, I will describe the prognosis of patients with multimorbidity. To begin, I'd like to introduce the construct of multimorbidity, which has several definitions. So multimorbidity is the presence of several coexisting conditions in an individual. These conditions can be related or not related to each other and include physical and mental conditions. There's no single index disease designated. And importantly, the conditions tend to endure and accumulate over time. So people start to continue and accumulate these conditions over a lifespan. And in terms of operationalizing multimorbidity, there are a few nuances in terms of the number and the types of conditions that are used to count multimorbidity. So to highlight one case, I'd like to share with you one of my most profound patients from residency. So Mrs. Smith is a 66-year-old patient that I met in my continuity clinic at Grady Memorial Hospital. And when I met her, she came in to follow up on several chronic conditions. But the focus of her visit had been debilitating knee pain that had limited her ability to walk over the past several months. So her past medical history included 4 common chronic conditions, and she was on 6 medications for these conditions. So for today's visit, I diagnosed her with osteoarthritis of both knees, and I recommend that she start physical therapy and take acetaminophen as needed. So at this office visit, I add osteoarthritis to her 4 current chronic conditions, but over time she presented with new symptoms. So during my second year, she presented with hematuria that was diagnosed as bladder cancer. The following year, she was brought to the emergency department by ambulance and hospitalized for an acute heart attack that was complicated by heart failure. And then in my final year of residency, I had gotten to know her quite well and noticed that she had new symptoms of insomnia and depressed mood. And at present, I don't know what additional conditions she's accumulated, but I wonder how these conditions have impacted her function, her health-related quality of life, and her overall prognosis. And she challenged me clinically and also inspired my research interests in how we can improve the quality of care and prognosis for patients like her. So now that I've highlighted some of the clinical significance of multimorbidity and why it's important to capture, I'd like to discuss how to measure multimorbidity. So prior measures of multimorbidity have strengths and limitations based on the disease selection, the incorporation of severity, and the patient setting. So first, clinical gestalt is important, but varies widely among individuals. It can be hard to quantify, and it also requires that the patient be seen, which is not always the case in population-based studies. So second, counting diseases is straightforward, but that doesn't take into account the potential heterogeneity and how conditions impact individuals and their health outcomes. So beyond counting conditions, others have felt that we should weight the diseases based on things such as mortality risk. So two landmark studies by Charlson and Elixhauser use weighted indices. However, these are limited to data from hospitalized patients, which are not necessarily applicable to the individuals in the outpatient setting, such as the differences in the diseases they have, the differences in the levels of acuity, and then the overall types of patients who are hospitalized or not hospitalized. So if patients are seen in clinic or hospitalized, another idea was to use cost and utilization to inform disease weights. So the Centers for Medicare and Medicaid Services developed the hierarchical condition categories, or HCCs, in the 1990s, and these were implemented in 2003. However, this assumes that the patient has had prior utilization and cost, but most community dwelling adults are never hospitalized, and this doesn't allow us to identify rising risk patients. So therefore, we need a modern, validated, comprehensive, and universally applicable measure of multimorbidity for community dwelling adults. So that's one of the first projects I embarked on in multimorbidity, was to develop and validate a multimorbidity weighted index that weights conditions by self-reported physical functioning. I then mapped these to ICD codes and validated it for use in claims data. So to illustrate some of these measures, using disease count, Mrs. Smith would have 4 conditions in 2010, and this would increase to 8 in 2013. One of the first and most cited measures for comorbidity that was then used for multimorbidity is the Charlson Index. It includes 19 conditions and was designed to predict mortality in hospitalized adults from an academic medical center in 1984. And it weights the diseases as follows. These conditions are weighted 1 point, while other conditions are weighted 2, 3, or 6 points. Because we lack measures for disease severity using other health outcomes, this measure has frequently been used as a proxy despite not being designed for those other purposes. So using the Charlson Index to measure multimorbidity, Mrs. Smith would have a score of 1 in 2010, and this would increase to 5 in 2013. But because conditions like her osteoarthritis and depression were not directly associated with 1-year mortality, they were not included in the Charlson Index. So therefore, this index would have underestimated her multimorbidity as an outpatient. So the Charlson Index weights diseases to mortality. And while mortality is an important outcome, it is not the only outcome of value, especially for older adults who are surviving with disease. So one of the questions then is, how can we measure disease severity in a more person-centered manner? So for most older adults, there are other outcomes that are valuable. For example, basic mobility, activities of daily living, and hobbies such as gardening. And then for my parents, it's reenacting scenes from The Sound of Music during our trip to Salzburg. So of all the possible ways to weight diseases, I'd like to make a case that physical functioning or physical health-related quality of life is an important outcome. Physical functioning is a universal value for people of all ages. It declines with age and disease accumulation, and it reflects the totality of the impact of diseases on a person. There's also a wide range of function that applies to sicker as well as healthier individuals. So it's an important clinical outcome. And then as opposed to later outcomes such as disability, declines in physical functioning may be targeted earlier. There are also opportunities to intervene, such as with physical therapy and early ambulation, to try to slow down the rate of progression of physical functioning decline. So for these reasons, it is a good measure or a good way to measure multimorbidity. So given the importance of physical functioning and how it serves as an important outcome for multimorbidity, I developed and validated an index for chronic conditions where diseases are weighted to physical functioning. I then externally validated this index in the Nationally Representative Health and Retirement Study and demonstrated that it is also strongly associated with subjective and objective physical and cognitive outcomes. So I describe these processes in the next slides. So in the multimorbidity weighted index, diseases are weighted to the short form 36 physical functioning scale. The short form 36 is one of the most common and validated measures for health-related quality of life. Benefits include standardized content and scoring. It's a continuous measure from 0 to 100, and it has a mean of 50 and standard deviation of 10. And the physical functioning scale is highly correlated with physical health-related quality of life. These are the 10 items in the physical functioning scale. It ranges from basic activities of daily living on the bottom, like bathing or dressing, and it spans all the way up to vigorous activities like running and lifting heavy objects. So I conducted a longitudinal analysis with each chronic condition as the exposure and then physical functioning with the SF36 as the outcome. I had over 729,000 observations from 3 large cohorts of community dwelling adults who spanned a broad range of young, middle-aged, and mostly older adults. I had repeated measures of chronic conditions and physical functioning, so I used mixed effects models to account for correlated data and missing observations in some years. I examined for effect modification by age and sex, but did not find any consistency for diseases. So then I did a meta-analysis to combine the weights for the diseases in each of the cohorts. I started with 374 conditions. I narrowed this to 81 in the index that could be stably estimated. And then the final index includes 74 conditions that have weights to physical functioning. For validation, I internally validated it through bootstrapping and cross-validation. And I also assessed the external validity as well as several forms of criterion validity. One of the strengths of the index is its twofold clinically meaningful interpretation. It represents both overall disease burden as well as physical functioning. So a 1-point increase in multimorbidity was associated with a 1-point decline in physical functioning. And the index conveniently calibrated such that 1 point of multimorbidity was essentially 1 point of physical functioning. To help illustrate this index, this histogram shows the impact of the top most prevalent chronic conditions and their impact on the short form 36 physical functioning. So the chronic conditions are listed on the left, and on the x-axis is the regression coefficient for the SF36 physical functioning. So as you can see, diseases had a wide-ranging impact on physical functioning, even among these top chronic prevalent conditions. It's also important to note that diseases are not directly associated with mortality, such as osteoarthritis, but they are still common and highly debilitating. There's also a wide-ranging impact on diseases that would be underestimated if just counting conditions. So these are Mrs. Smith's conditions, and there are weightings in the multimorbidity index. I also examined diseases with the worst impact on physical functioning. In general, they're the progressive neurologic conditions such as multiple sclerosis, Parkinson's disease, Alzheimer's disease, ALS, followed by end-stage organ diseases such as heart failure, COPD, chronic kidney disease, arthritis, and dementia were then weighted with the worst functioning. So for patients with multiple sclerosis, there was more than a 1 standard deviation worse physical functioning than those without multiple sclerosis. And Mrs. Smith had 2 of these more end-stage conditions, heart failure and chronic kidney disease. So based on the multimorbidity weighted index, Mrs. Smith had a score of 9.4 in 2010, and this more than doubled to 21.3 by the end of 2013. And as you can see, she has the highest burden of disease based on multimorbidity using a multimorbidity weighted index. This index is automated and freely and publicly available for use. And one of the highlights was its addition to the ePrognosis website. Also, to make this index available for claims data, I mapped the conditions and validated them for use with ICD-9 and ICD-10 codes. And I also share the SAS and STATA macros for developing these. Given that other measures have been used for claims data, my next undertaking was to do a direct comparison of the ICD-coded multimorbidity index with existing measures. And one of the major strengths was that it had the widest distribution at both the low ends and the high ends of multimorbidity. It also had the least left censoring, where 5.5% of individuals had values of 0, compared with 35% with a Charlson score of 0 and 15% with an Elixhauser score of 0. And this is a sample of Medicare beneficiaries linked to Health and Retirement Study. The multimorbidity index also had the most unique values, so it enables a more precise measurement of each person's multimorbidity without ties. In addition to the distribution and unique values, there are a few other advantages. So compared with other metrics, the multimorbidity index had the greatest contrast across the high versus the low quartiles. It had the best coefficient of determination and model fit, and the best prediction for future physical functioning, and a similar prediction for 10-year mortality, despite not being designed to measure mortality. So now that I've discussed why to measure multimorbidity and some ways to measure multimorbidity, I'd like to highlight some of the prognosis for patients with many conditions. This is a conceptual framework I have used to think about how multimorbidity impacts a person. So multimorbidity is a number of diseases that interact with each other. There are risk factors for getting multimorbidity, such as age, socioeconomic status, lifestyle factors. And then downstream to multimorbidity, it impacts bodily functions that then progress to disability, which we can measure by basic and instrumental activities of daily living. These then affect participation, which we can measure through health-related quality of life and social participation scores. And then the final ultimate outcome is mortality. But as you can see, there are several outcomes upstream to mortality. So I've examined the association of multimorbidity with all of these outcomes, and I will highlight a few in the next slides. First, the multimorbidity index predicts 10-year mortality. So in this graph, the x-axis is the multimorbidity weighted index in quartiles, and the y-axis is the hazard ratio for mortality. So as multimorbidity increased, the hazard ratio for mortality increased. And this was the case even after removing Charlson conditions from the multimorbidity weighted index. This suggests that conditions not included in indices weighted to mortality also have an impact on a patient's mortality risk. I have also assessed the performance of the index by examining its associated with subjective and objective measures of physical and cognitive function. I highlight a couple outcomes here. So on the x-axis is the multimorbidity weighted index in quartiles. And as multimorbidity increases, there's a significant monotonic gradient with the worse grip strength as well as worse global cognition. I've also demonstrated that these associations persist longitudinally. Further down the continuum of functioning, I examined disability measured through ADL and IADL limitations. On the x-axis is the multimorbidity weighted index in quartiles, and the y-axis is the number of ADL and IADL limitations. The ADL limitation is shown in red, and the IADL association limitations, are shown in blue. And there was a significant dose response associated with increasing quartiles of multimorbidity, and this association was significantly nonlinear. I also demonstrated this association longitudinally. In terms of health-related quality of life, the multimorbidity index is weighted to physical functioning, but we know that mental and physical health are intricately linked. I thus examined associations between the multimorbidity index with future health-related quality of life, and here it is associated with all the domains of physical health-related quality of life, as well as all domains of mental health-related quality of life, even 8 years later. One of the worst possible outcomes of poor mental health is suicide mortality. And in this study, with over 24 years of follow-up and 3 large cohorts, the multimorbidity weighted index was associated with increased risk of suicide mortality. Beyond individual health outcomes, I've also examined how the multimorbidity weighted index is associated with healthcare utilization. I will highlight one study here using the health and retirement study in Medicare beneficiaries. In this study, with 1 point increase in multimorbidity, there was a 4.3% lower odds of having 0 hospitalized days. And among those who were hospitalized, there was a 2% greater number of hospitalized days. So in summary, I've demonstrated that multimorbidity increases over time and predicts several worse health outcomes in different longitudinal samples. It is associated with all-cause and suicide mortality, subjective and objective measures of physical and cognitive functioning, disability using ADL and IADL limitations, social participation, physical and mental health related quality of life, hospitalized days, and office visits. Here are a few references on the multimorbidity weighted index if you would like to read more. And I'd like to thank my mentors and research group for these projects, as well as many collaborators. I'm happy to take questions. Thank you so much.
Thank you so much to both of you for excellent presentations. I'm excited to have a great discussion. As a reminder to our audience, please use the blue circle chat or Q&A function to submit your questions, and then we will read those. So for our first question, for the first presenter, you talked about the function and quality of life, but not symptoms. Do you think that symptom indices and symptom clusters could be important to your work?
Yeah, that's an excellent point. And I think we could certainly put in symptoms experienced by patients as one of the ways of identifying how a particular combination of multimorbidity conditions impacts patients' lives. So certainly we could do that.
So for the second presenter, the conditions in your index are often progressive, with a wide range of potential impacts on the individual. What do you think about stratifying the weight based on factors like disease status, for example, in the heart failure class?
So thank you for that question. That's an excellent point. So I agree that it is important to capture different gradations of disease severity. And I think one of the challenges is that there are different ways of measuring disease severity for each condition. So for example, heart failure has New York Heart Association, and then there are other measures that don't have as clearly defined ways for measuring severity. So for example, in osteoarthritis, it doesn't necessarily correlate with the medications or the imaging results. And so that can make it hard to rate the severity. And when we rate severity based on subjective outcomes, it can be hard to average out in a population study. So one way that I tried to address this in my measure was that I took all of the possible years of data in an individual over time. So spanning 3 large cohorts, starting from 1987 all the way to 2016, I had repeated measures of data. So individuals reported their chronic conditions and their physical functioning basically through several years of their life. And so by that way, I was able to capture the impact of the diseases on physical functioning over time. And the weights are basically just an average of that disease impact on an individual. So it doesn't capture when it's in its most severe state or in its less severe state, but it captures kind of an overall impact that it has in an individual. So there's definitely more work that can be done here. And I think one of the challenges is finding a consistent way to rate the disease severity across all the conditions that we might consider.
Can I tack on to that a little bit?
Yeah, please, Anna.
I'm really interested too in thinking about your work and the way that you're thinking about multimorbidity progression through this weighted index and how that evolves and changes over time. And with this, the first question asker around incorporating severity. So ultimately, I think there are these kind of conceptual pieces, and we're trying to figure out where we have data, where we can identify and operationalize ways of picking up, right, what some of these impacts are. So including symptoms, including pain scales experience. I'm just trying to think about ways that we do measure and contact patients and respondents and ask them about these things that we could then incorporate, if we're thinking about this longitudinally and how multimorbidity changes over time, and then this kind of lagged or sequential cascading of effects of increase in symptoms, increase in complications, right? So really trying to examine that progression over time of patients that may have diabetes, arthritis, and hypertension, for example, is a combination, but may be in a stable management of those conditions. So the progression may be flat, right? It just might be constant. But what we really want to try to be able to disambiguate or identify are those groups of patients that may be worsening over time in ways that we can intervene on. So progressing their diabetes, there's some ways that we could try to think about that clinically, progression of diabetes maybe to end-stage renal disease, that we can pick up on, we can identify. Other kinds of procedures, retinopathy, or other kinds of ways of identifying and signaling complications or procedures, amputation. I think these are ways that we could try to figure out what these markers are and these time-varying, time-sequenced markers are that try to help us understand for the progression of multimorbidity where we see complications and an increase in severity.
Thanks, Anna, that's excellent. I was just thinking, so, it is possible to examine and add all of these factors in for individual diseases. It'll take a little bit of time for the number of conditions, but there have definitely been studies that have added additional data such as medications, procedures. And I was also just thinking about Matt Masjewski's article looking at disease duration as another way to try to capture the severity of diseases. So there are other approaches, some that would apply to all conditions, but probably would need a more individualized approach.
Yeah, really important, really complicated, but super important. I think the field is really grappling with this right now and improve on that measurement. Yeah.
That's a great conversation. And this kind of another question is maybe a good jumping off point. Has there been work associating modifiable, so behavioral risks with rating on the multimorbidity index?
Yes. There's been a lot of work on all manner of potential risk factors and as well as potential mediational or moderational types of mechanisms that may be occurring. So in our team, we have a couple of quantitative psychologists that are very interested in this, in thinking about sedentary behavior and in thinking about BMI as a potential moderator and a potential mediator. So we're exploring this, but we're by no means the only folks doing that. There's lots of work out there trying to examine the mediational pathways of lifestyle factors such as exercise or sedentary behavior, smoking, other kinds of potentially modifiable factors.
Yeah, I agree with you, Anna. There are a lot of risk factors that are common across several conditions, and so therefore there could be really big impact by targeting those individual conditions. I'm also thinking about other constructs that might bring us some hope in terms of effectively intervening on individuals with multimorbidity, which has been a real gap in the literature. So one study I like to highlight was looking at multimorbidity with social participation. And we were looking at purpose in life and life satisfaction as potential modifiers of the association with multimorbidity. And interestingly, individuals with high purpose in life were essentially buffered for low social participation, regardless of having really high multimorbidity over time. So I think there's some promise with some measures such as purpose in life and life satisfaction. And there's also a lot of work being done in resilience. So people like Heather could also highlight some of those studies, but we're definitely searching for ways to modify the the risks of multimorbidity, and there's definitely some work needed here still.
So Melissa, we have a specific question about your slide 12. The viewer was wondering, why are all of these disorders increasing so sharply over time? Is that real, or is that just a data source phenomenon?
Sorry, I'm going to go back to my slide 12. So slide 12 was the Charlson Index. I think I might be missing the slide. Was it the one where the conditions are increasing over time, as in people are getting more conditions over time?
Yeah, maybe that was a mistype. Maybe you had a slide that had data from 2009 to 2019 of the common and uncommon, and you see the lines all rising sharply over time.
That may have been mine.
Oh, maybe that was yours. I'm sorry. Anna, do you want to get us that?
Yeah, I think, I mean, because I'm only recognizing the pattern that you're mentioning, and I believe that that's what the advanced data, 2009 to 2019.
Yeah, that's probably what it is.
Okay.
Yeah, so it's not an artifact, but that's just keeping in mind that there are different clinics that come in, come out, different, the population, it flexes. So yes, obviously it's going to be a reflection of that. And then the 18 to 19, you want to censor that out. Again, it could just be new clinics that come into the consortium or the advanced network. But again, I've tried to caution everybody, this is very, very preliminary, individual conditions, and the denominator changes and fluctuates quite rapidly as more clinics entered into the repository.
Okay, that makes sense. Thank you. Sorry, I apologize for the confusion on the speaker in that one. So another question, I'm not sure who this one is to. Maybe you guys can decide. It sounds statistical. So you consider interaction terms in the model to account for synergies. Another conceptual piece would be orthogonal conditions versus co-occurring. Shared RF to pathology versus complications. For example, renal disease secondary to diabetes. Does this make a difference?
Yes, this is a great question. Anna, should I start? So I'm working on looking at disease interactions currently, and there are a few challenges, such as the higher dimension aspect of it. So when you want to include, say, 50 conditions that can all potentially interact with each other, you get 50 factorial combination of different potential interactions. And with some of the more novel methods in machine learning, we're able to do things like decision trees and lasso and shrinkage. But then the challenge has been how to interpret these interactions. So if a computer can generate a lot of statistical associations between different diseases, what does this mean from a clinical standpoint? So in terms of a large, broad approach of looking at all of the conditions, this has been some of the challenges. And so some of the more recent studies have looked at other ways of clustering conditions, or using latent class analysis, other ways that are more clinically relevant, in addition to having robust statistical measures. So I think that there's a lot that can be done there. And in terms of diseases that are orthogonal, there are definitely conditions that together can be worse synergistically, and then there could even be conditions that when combined could actually lead to potentially better outcomes. And that, say, for example, if an individual has hypertension as well as chronic kidney disease, and those have overlapping medications, it would help to motivate the person to take their medications better, because this medication is going to help impact two of their chronic conditions. And so that's an example where it could actually potentially be helpful. So there's definitely a lot of really rich and exciting things going on with disease interactions. So stay tuned.
Yeah, and I would add that this is really, from my reading of the tea leaves, this seems to be where the field is really going. So Melissa said in her presentation, really moving beyond simple counts, although there's value in doing, drawing crude pictures around what that looks like for a population over time. but really trying to think about specific disease combinations, and that could really have a little bit more of clinical impact in terms of trying to motivate patients and counsel patients on how to manage their chronic disease. We've had some difficulty, and I think, Heather, maybe you can speak to this too, around some of the more advanced methods and trying to understand what underlying patterns or underlying latent classes or underlying combinations or interactions are. We've actually found a lot of value in just doing, starting simple and looking at, simple tabulations of what might be occurring more frequently. So some of this depends on what you're interested in and the perspective in which you're looking at how these multimorbidity combinations or patterns matter. So what do they matter in terms of a prevalence standpoint, thinking about particular global populations or subpopulations, what might be more prevalent there? Does it matter to treatment burden? Does it matter to, thinking about combinations of chronic conditions that are really high burden in terms of management, in terms of impacts on the time and the work that we're asking patients to do to manage their chronic conditions? Also burden to clinicians, multiple appointments, multiple ways of asking both the healthcare system and patients on tracking and engaging in very intensive and labor-intensive self-management activities and management activities. So I think it depends.
Yeah.
Really unsatisfying answer, but I do think that it's difficult to start, and this is again where I think it's really messy and really exciting to think about how to determine, what's related, what's concordant, what's discordant. And again, it depends. It depends on a particular etiology and a particular way that a multimorbidity combination has progressed for that particular patient. So the pathway of accumulation matters in terms of trying to think about concordant and discordant. So maybe starting simple, I think, is the approach that we've taken, and I've found a lot of value in looking at things that way.
I agree, Anna. That's really a great point. I was also just thinking about a study that looked at just ADL limitations, and they showed that essentially when you add depression to any of the conditions, then it had a synergistic impact with worsening the ADL limitation. So that was an example of just a very focused set of conditions, very focused outcome of interest to demonstrate the interactions there without kind of adding all the possibilities available.
Yeah, absolutely. And we've found a lot of big take homes with, so not every study. So I think I mentioned early in my talk, it's really important for us to be very transparent and open about how we're calculating that numerator, what we're including. Data sources are depending on a particular framework that we're using. And it hasn't always been consistent to include mental health conditions. I think depression is a great example of a chronic clinical depression that can really impact self-management activities, can really impact and complicate symptoms, complicate progression, complicate a lot of other underlying physical or somatic conditions that may be co-occurring. So really interesting discussions that we're having, and I think they're really important issues to sort out.
Agreed. Especially a lot of the indices include mostly physical conditions compared with mental conditions. And it's not that the mental conditions are less important. I think part of it is challenges in being able to capture and then validly measure some of the mental conditions. So at least in some of the work, I feel like sometimes it's undercoded, and even if the condition exists, you might not necessarily have a large and robust enough sample size to say with confidence that this is the impact that this condition has on, the outcome that you're looking at. And so there's definitely a lot more room to examine the impact with mental health conditions and multimorbidity.
When you both think about the data you've mentioned, you're limited by the data that's there, and you think about the clinic and treating these patients. If you had your wish list, were there the top 3 things you wish data were being collected, or thinking of changing practice? What do you wish the health system or a physician would be tracking that you could have and use in your modeling?
Do you want to start, Melissa, or can I go?
You want to go, Anna, or do you?
Yeah, I mean, I think, so I'm actually going to be more the pragmatist here and put on my pragmatic hat of, it's really valuable just to be transparent about how you're measuring it. And the perfect shouldn't really be the enemy of the good, and giving us some data points, even if it's a little fuzzy in the beginning, and as we start to refine things as we move forward. There really isn't a perfect data source. I mean, I think when folks talk about ideal data sources, again, for what purpose, again, for what outcome, we get some really nice glimpses if we're able to triangulate and use multiple data sources, because you're really looking at it from different perspectives and different points of view. So patients can only appropriately self-manage what they believe and what they report they actually they have or they may have. So self-report is really valuable. Clinical information is extremely valuable. You have some really nice depth of information there. Would be nice if we were collecting things consistently. So this list of 20, or again, the Health and Human Services article that I reference isn't the only article out there, isn't the only multiple chronic conditions framework out there. There are multiple. There's a lot of variation across different international groups. So there are a lot of validated denominator type guidance papers out there in other national contexts that are important for those particular nations and those particular country populations. So I don't know that really exists as kind of perfect, but it would be nice if we could have a more comprehensive set across some of the more cost-effective ways that we sample patients or sample community living respondents with our large national longitudinal surveys. But I'm just not averse to using multiple sources of data to try to get better and better at measuring this.
Yeah, that's great. In terms of like a wish list for data measurement, I mean, I think it's so amazing that some countries have birth to death data on the population, like that really great article in Scotland looking at social deprivation and multimorbidity from birth to death. I thought that was just an amazing article, an example of how you can really look at multimorbidity and some of the risk factors and outcomes over a lifespan. So we don't have those data, at least in the US, but some ways of trying to get around this aspect are using simulated data approaches to try to patch up and match up individuals who would fit those gaps in the years that you're trying to capture. And then also there are a lot of harmonized data. So for example, the Global Gateway to Aging has combined measures across several countries that are in common. And so that way you can get at least a diverse population in your sample. And I also like to think about all the different ways of capturing data. So being a fan of self-report and patient-reported outcomes, I think that is a really valuable measure. But then it would also be nice when these are linked with claims data. So some data sets that do that are NHATS and HRS, which are linked to Medicare, although you can also have limitations within the age. But what would be really neat is if we then also merge these data with the electronic health record. So if you could have self-report plus electronic health record plus claims. And some studies are even linking measurable devices, like measurable personal devices like Apple Watches, to EHR data. So I think there are a lot of creative ways that people are combining data in rich ways. And so over time, if we could basically try to merge all of these and then use simulated data to fill in the gaps over time, that would be a really, really cool opportunity to measure multimorbidity over the lifespan.
Absolutely agreed. Yeah. Great points.
So another question.
Possible, maybe not at like, oh, sorry, go ahead. Yeah, I think
you keep going. That's good.
No, yeah, please go ahead.
So another question. The MWI is very interesting since there are so many differences among MCC population in their self-reported function. The PCS component of SF36. How does the MWI translate among age strata and subgroups? Do you have any plans to look at this?
That's a great point. So yes, so there are some conditions that have remarkably tight confidence intervals for conditions, even when I broke down by above and below median age cut points, as well as looking at different sexes, so between men and women. I think across the board, there's actually a lot of similarity in the younger and older adults and the men and women more than we think. It's possible to look at the individual data sets to have the most precise measurements from these cohorts of individuals. And so that would be a way to get, just the younger women or just the older men to capture these individual conditions. I would like to do more of an in-depth analysis looking at breaking these individuals down by decades and over time. And that would be an exciting project to do. And if anyone wants to help out with that, I would be game for that.
Well, and a follow-up question to that, thinking about both of your presentations, how do you think about the populations not responding to the functional survey questions in the SF-36? If you think of how it was validated, how does this affect that application if you didn't have diversity in that initial validated study?
Yeah, so that's a great point. So in the individual development cohorts, it was a fairly homogeneous population. One of the strengths with using nurses, health professionals, are that they're really good at self-report in their conditions. And they also had really high response and very low attrition. So I was able to get a lot of data over time, but exactly the point is that it's not a diverse population. So one of the important things to do is then to take the index and see how does it perform, does it validate in other populations. So then I looked at the health and retirement study where we have national representation and oversampling of Blacks and Hispanics. So I thought it was very important to demonstrate that the same patterns of how diseases impact physical function were also seen in the health and retirement study. And then also similarly among Medicare beneficiaries where we have an older population. But there's definitely always room to continue to validate, continue to look at different populations, especially those who are not contributing to the data. So one example is that multimorbidity is really severe and occurs at early ages in homeless populations. So there are studies in Australia capturing this, but they're not a population that we can commonly examine. And it would be really nice if we could find different ways of measuring to see if the current weights we have also apply to these other groups.
Yeah, Melissa, I think you're basically making the argument that you and I need to work together and validate.
Oh, right. Yeah, there's just a lot. There's so much. There's always more to validate, and I think there can be a never-ending. There's always a need to validate, and I think it's so important to always know where your data came from, who it may apply to, who it may not apply to. And we can always start with internal validity and maximizing that, but then also very importantly to assess the external validity in the populations that we're applying these measures to.
Absolutely. So I think it would be really nice to think about and explore some ideas around validation of MWI across other data sources that may get at some of these groups that are typically underrepresented in research. So the Advanced Data Network, these uninsured, underinsured Medicaid, indigent populations would be great. I think this does highlight the difficulty then in some data sources. So in those data, in the advanced data, these EHR repository data, I've looked through, and unfortunately with clinical data, often those functional assessments are missing. Those fields are there.
Right.
It's complete, right? The completeness is often lacking.
Yeah.
And I do think it's so important, and I love the fact that MWI is weighted to some kind of functional consequence, some kind of functional outcome. But that's the point around sometimes we're limited by data availability. And there may be other ways that we could capture some kind of patient-centeredness and patient impact or impact on patients' lives that we can also use to weight.
Yeah, I totally agree, Anna. There's always like a breadth versus depth issue with the different data sources. And I think part of the motivation for weighting diseases by physical functioning was because physical functioning is a really important outcome, but that it's not consistently clinically collected. So it's not always in EHR data in a way that we can extract it easily. And then it's not in claims data either, because that's not self-report at all. And so if there's another workaround, this was a way to try to get that domain in the data, but through the diseases, which we pretty much always have, whether through self-report or claims or EHR, it's pretty easy to get a list of conditions. But then if we want to do a little bit more than that, we can try to figure out other creative ways to integrate those other domains.
So I have another question. I'm hearing and reading a lot about the impact of loneliness and social isolation. For example, increased risk of dementia, death from heart failure, stroke. Are you seeing social isolation having an increased impact?
If you don't mind, Melissa, I'll take the first crack.
Yeah, Yeah, go for it, Anna.
Yes, very much so. Well, not in answer to your question of seeing social isolation, but in terms of seeing importance of biopsychosocial factors or the psychosocial interacting with the bio and the medical complexity, absolutely. A colleague of mine, David Dorr here at OHSU, we've been thinking about this particular issue, the distinction between loneliness and social isolation, and thinking about that conceptually as it pertains to populations with multimorbidity, and trying to get that grant funded, but hasn't been a good convincing sell to the study section so far. But we are very interested in this question and very interested in these issues. Very important. Couldn't agree more that I think that they're very, very important.
Yeah, agreed, Anna. So important with social isolation and loneliness. And it's great that they're increasing studies, especially as the measures for constructs like loneliness increase over time, and also social isolation, where it's not just number of social networks and quality and quantity of social networks, but more of how individuals perceive their loneliness. I'd like to highlight one of the papers that just came out by Nazli Abedini. So she was looking at loneliness and end-of-life care in the health and retirement study, and then she used the multimorbidity weighted index to adjust for all the chronic conditions. And so there we did see that individuals had very high levels of multimorbidity. So it's definitely very important to increase our knowledge in these constructs.
So another question, Melissa, what challenges have you encountered in incorporating dementia into the MWI, given how reliably or not reliably this is coded in the medical record?
Yeah, so that's a great question. And then I'd add another challenge is that dementia wasn't as consistently captured in some of the data sets. So they would ask questions like, have you had memory changes, but not necessarily labeling it as dementia. So in the original cohorts, the dementia was also self-report, but there was also an option for proxy respondents. And so there I did take a look at individuals and how many were contributed from proxy individuals. And so that's an example of where it's very helpful to have proxy respondents for dementia. Similarly, in the health and retirement study, there's an option for proxy measures of dementia. So it's not a direct measure, but it's something that can be captured at least suboptimally, which is better than nothing, I believe, in this case.
Well, that was our last question. I want to thank both of you for excellent presentations and such a lively discussion. We really appreciate your time and what amazing work. I would like to let you know that this seminar was recorded and the slides and recording will be available on the Aging Initiative website. Thanks everyone so much for joining us, and we hope to see you at our next webinar.